Hello, my name is Vivian Fonseca from Tulane University Medical Center in New Orleans, Louisiana. So I want to address the question of whether data from new post-hoc analyses of studies like ADVANCE, SOS, and VADT can change practice. Large multi-center trials usually offer us definitive answers to important clinical questions, primarily through proving or disproving the hypothesis related to the primary endpoint. Some pre-specified secondary endpoints also yield information that can change clinical practice, although one has to be careful about testing too many endpoints. Just by chance alone, something is likely to be statistically significant. However, these clinical trials do have other data that is often mined for information that may be useful in generating new hypotheses, although one needs to be cautious in drawing definitive practice-changing conclusions from such analyses. This issue of NDAI's clinical insights in diabetes provides us with post-hoc analyses from three major databases that lead to provocative conclusions. Can these new data change practice? First, Morton et al. Show that in participants in the Action in Diabetes and Vascular Disease Pre-Thorax and Diamicron MR Controlled Evaluation Trial, also known as the ADVANCE trial, low levels of high-density lipoprotein cholesterol, or HDL cholesterol, are a risk factor for renal events, in addition to their predictive value on macrovascular events. Unfortunately, their definition of renal events is rather broad, ranging from new onset of microalbuminuria, which is somewhat soft and variable, to the hard endpoint for need for dialysis or death from renal disease. Furthermore, they have neglected to correct for the large impact insulin resistance has on renal disease. It is well known that the low HDL cholesterol is a marker of insulin resistance. Romeo et al. Report on a post-hoc analysis of a subset of individuals in the non-randomized Swedish obesity study, or SOS, who had type 2 diabetes at baseline. The authors demonstrate that bariatric surgery reduces the incidence of myocardial infarction among these individuals with type 2 diabetes compared to usual care. The results are not surprising, since there is no reason why subjects with diabetes would not benefit from this intervention compared to the overall cohort previously reported. What is unclear from the paper is the nature of what they call usual care, which may have been suboptimal, since those who did not have surgery had most risk factors significantly worse during the duration of the study when compared with those who had surgery. It is also possible that surgery was conducted only in those with less risk of complications of surgery, also known as selection bias, and a randomized trial is needed to truly confirm this hypothesis. Finally, Sarimi et al. Report that in the VA diabetes trial, or VADT, more frequent statin use was associated with accelerated progression of coronary artery calcium versus less frequent statin use. Calcification in arteries is a late stage of the atherosclerotic process, and it is possible that the statins helped heal lesions that subsequently calcified. The number of patients studied was 197, which is very small, making it difficult to draw firm conclusions. The study is confounded by the higher severity of disease in those motivated to take their statins. Much of it may be irreversible. We should most certainly not take patients off their statins to avoid calcification.